Breaking the silence. Expanding access to safe abortion in Zimbabwe. As Zimbabweans, we are always looking ahead to a better, healthier future for ourselves and our children. Our citizens are smart, resourceful, and resilient, with a vibrant spirit that is grounded in strong communities, deep faith, and rich culture. In matters of health, Zimbabwe has achieved many successes, even in areas that once seemed controversial and challenging. Zimbabwe's modern contraceptive prevalence rate for married women aged 15 to 49 has nearly doubled in the past 3 decades and is now 66%, the highest in all of Africa. The number of new HIV infections each year in Zimbabwe dropped dramatically in less than a decade, from 74,000 new infections in 2010 to 41,000 in 2017. Moreover, 95% of those who are aware of their HIV-positive status are receiving treatment. Our nation has succeeded in these once sensitive areas by overcoming HIV-related stigma, shifting cultural norms, and benefiting from strong political will and investments by the government. Still, many other areas need improvement, especially when it comes to outdated systems, laws, and policies that no longer serve the public. One important area that is lagging is maternal mortality. Zimbabwean women are dying in unacceptable numbers during pregnancy or childbirth, or within 2 months after childbirth. In fact, our maternal mortality ratio in Zimbabwe has increased over the past quarter century in sharp contrast to global trends. The maternal mortality ratio in Zimbabwe is 651 deaths per 100,000 live births, one of the highest in the world. This figure is much higher than our neighbors, Malawi, where it is 439 deaths, Mozambique, where it is 408 deaths, and Zambia, where it is 398 deaths per 100,000 live births, and we are far from achieving the World Health Organization's target for ending preventable maternal mortality, or EPMM, by 2030, with no country having more than 140 maternal deaths per 100,000 live births. Zimbabwe is already doing much to reduce maternal mortality by implementing effective interventions outlined in one of our key national health strategies. For example, by providing a package of high-quality antenatal care services, clean and safe delivery rooms, and emergency obstetric care, to name a few. Despite these efforts, too many Zimbabwean women are still dying, partly because we are not doing enough to address one of the leading causes of maternal deaths: unsafe abortion. According to the World Health Organization, or WHO, unsafe abortion is when a pregnancy is terminated by someone who does not have the necessary skills or in an environment that does not conform to minimal medical standards, or both. Globally, unsafe abortion accounts for about 1 in 7 deaths related to pregnancy and childbirth, and is responsible for countless cases of illness and disability. Our religious and cultural backgrounds can make the topic of abortion seem taboo in Zimbabwe, so we seldom talk about it. But this is a conversation we need to have, because this silence is devastating our women and girls. The truth is that unsafe abortions are happening in our country every day. In Zimbabwe, 4 out of 10 pregnancies are unintended or unplanned, and 25% of those unintended pregnancies end in abortion. In 2016, more than 65,000 induced abortions occurred in Zimbabwe. Most of these abortions were clandestine and potentially unsafe, performed outside the formal health system. There are many reasons why a woman or girl may have an unintended pregnancy and seek an abortion, such as limited knowledge or access to contraception, failure of a contraceptive method, bed timing to have children, health concerns for herself or the fetus, pregnancy as the result of rape or incest, worry about finances, desire to pursue or complete an education, preference to stop having children, stigma attached to having a child outside of marriage. Evidence shows that women of all ages and backgrounds seek abortions, whether they are rich or poor, married or unmarried, and whether or not they currently have children. Of course, not all women have an abortion, but it is likely that you know someone who has, a sister, cousin, friend, colleague, or neighbor.
It's heartbreaking to witness how serious the effects of unsafe abortion can be. Fear and stigma are contributing to many of these deaths. Often, women are afraid of being judged or punished for the crime they think they have committed. So they present very late, too late for care, or some never even go to the hospital. Instead, they deteriorate outside the formal health system or suffer silently in their homes. I always ask, should women really be dying because they cannot get a safe abortion?
Many women and girls are driven into the shadows because of our country's restrictive abortion laws and a lack of clarity about their provisions. The 1977 Termination of Pregnancy Act, or TOP, is the main legal document in Zimbabwe that guides access to abortion. According to this act, a pregnancy can be terminated in 3 specific circumstances: if it endangers the life of the woman or constitutes a serious threat to her physical health, if there is a high risk that the fetus will suffer from a serious or permanent physical or mental defect, and if there is a reasonable possibility that the pregnancy is the result of unlawful intercourse, in other words, rape or incest. Not everyone is aware of this law and what it allows. This lack of awareness leads to confusion and fear, which can prevent women and girls from seeking an abortion and prevent providers and others from helping them to access the service. In a 2016 survey, only 25% of healthcare providers knew all the conditions for which abortion is legal in Zimbabwe. And in another survey conducted in 2018, only 25% of community members knew that abortion was even legal. But even if people have this information, the TOP, as it is currently written, creates many challenges by requiring a long chain of complex steps that can feel virtually impossible to navigate. For example, if a woman is a victim of rape or incest, she must file a police report, obtain a thorough medical examination, go to court with a police officer to present the file to the prosecutor, who then decides if the case is valid and if it should go to the magistrate. If it goes to the magistrate, she or he must review the evidence and decide whether or not to provide the pregnancy termination order. Even when a pregnancy poses a threat to the woman's life or health, the steps are complicated and challenging. In this case, an abortion can only be provided if a superintendent at a designated health facility gives written permission. The superintendent can only do this if the woman has been examined by 2 doctors who independently recommend abortion. These recommendations must come from either a doctor at the designated facility and 1 other facility, or 2 doctors who are not in the same partnership or practice.
In my experience as a legal practitioner dealing with women who try to access the justice system on a daily basis, you find that the steps that are outlined in the Termination of Pregnancy Act present a lot of challenges to women. Some of these challenges include failing to get the right personnel to assist at a local police station, the time it takes to finalize the investigation and prepare the necessary documentation to present to court, and at health institutions, the time it takes to finalize the medical tests and the medical examination. All this has a bearing on a woman's ability to access a termination order. It is also important to note that these stakeholders are not always found at the same place or same city at times. So it takes days, weeks, even months to just go through the different stakeholders, time which a woman doesn't have because a termination needs to be done within a specified time. Other countries don't have such cumbersome processes, and it's time for Zimbabwe to review its law to enable access to safe abortion.
Zimbabwe's complex abortion law and the burdens it imposes are important reasons why so many thousands of women in our country resort to clandestine, potentially unsafe abortions. Only the few with enough money might be able to find other ways to get a safe abortion by visiting a private provider or traveling to South Africa. We need to do better and ensure our justice system protects all Zimbabwean women. Restrictive abortion laws like the 1977 TOP do not actually reduce the number of abortions that occur, and permissive laws do not necessarily lead to more abortions. What does change, however, is the safety of abortions. In regions such as North America and parts of Europe, where abortion has been broadly permitted for 20 years or more, nearly all abortions, more than 9 in 10, are performed safely. In contrast, in Africa, where most countries have restrictive laws, only 1 in 4 on average are safe. When abortions are unsafe, they are more likely to lead to complications that would be extremely rare if they had been carried out according to WHO guidelines. Women and girls with abortion complications need post-abortion care or PAC, a service that is supported by the Ministry of Health and Childcare. According to a 2016 study, 2 in 5 women in Zimbabwe who sought PAC had moderate to severe complications, such as infections and injuries to the uterus that required treatment. Women aged 30 and younger and those living in rural areas were more likely to have more severe complications from abortions than older women or those living in urban areas.
In my work in a women's health organization, I meet several women and girls who have suffered unsafe abortion. I also hear first-hand accounts from their relatives and friends about the trauma they experience. One woman who had 3 children and whose partner was angry that she was pregnant again. Although she knew about safe abortion services, she couldn't afford it. She went to a local woman who inserted a cloth hanger. After 2 days of bleeding and fever, she went to the clinic. The nurse told her she had an infection and that she was lucky to survive. I knew of 2 others who weren't so lucky. One, a young woman whose mother was worried about what the church would say about her pregnancy, took her to a local herbalist who gave her some herbs to drink. Another, a university student, took abortion medication far too late in her pregnancy and without any medical supervision. Both of them died.
Only half of the women who had abortion complications in 2016 got the care they needed. There are many reasons why women did not get the right care, including a limited number of facilities that offer basic or more advanced PAC services. Stockouts of critical drugs. In a 2016 survey, more than half of existing facilities that provided PAC did not have essential medicines to treat abortion complications. a lack of the right medical equipment at the facilities to provide appropriate PAC, and finally, challenges for women to bear the costs of transport and supplies. PAC is costly to provide because it requires skilled personnel, surgical procedures, drugs and supplies, and hospital stays. Much of this care wouldn't be necessary if abortions were carried out safely in the first place. One well-regarded analysis estimated that the annual cost of providing PAC in all developing countries is around $232 million. But if all abortions were provided safely, this cost would drop more than tenfold to about $20 million. Regardless of our own beliefs or the choices we might make personally, we can still empathize with women and girls who find themselves in need of safe abortion. We have the power to prevent unnecessary deaths and disabilities. We can start by breaking the silence and talking about the critical issues. We should acknowledge that the 1977 TOP is not suited to the current realities in Zimbabwe. Let's talk about how this act has many shortcomings and contributes to unsafe abortions and preventable complications, deaths, and emotional trauma, costing our country precious resources. It is time to consider some major reform to the TOP. The law should be reformed to be in line with WHO guidelines that call for ensuring that all abortions are done with the appropriate method and either supported or performed by a trained provider. Eliminating access, regulatory and policy barriers, and amending restrictive laws that criminalize abortion and threaten women's lives. When these reforms are made, we need to ensure that women, healthcare providers, and all decision makers are clear about what is legal so they can make well-informed choices. We should close the knowledge gaps that exist when it comes to sex and family planning. Let's talk about how to ensure that girls, women, and couples have accurate information and contraceptive options so they can prevent the unintended pregnancies that commonly lead to abortion. And finally, we should remedy the poor state of our health facilities. Let's talk about how to ensure that we have enough facilities with adequate supplies and equipment to provide safe abortion and PAC services. We must meet the challenge of addressing these important issues. It is time to break the silence, to raise our voices, and to make the changes needed to protect women's lives and ensure the world sees Zimbabwe as a leader when it comes to health and policy. Now is the time for action.